Welcome to this explainer. Today, we're taking some seriously dense medical guidelines about fetal growth and translating them into a clear, step-by-step clinical pathway. We rely on a whole lot of acronyms and medical jargon in the delivery room, but today we're going to break all of that down and look directly at how these critical assessments are actually made.
So let's just dive straight into a classic medical mystery that so many expectant parents run into. And it usually starts with the single ultrasound measurement. Figuring out if a baby is just constitutionally small, meaning they're perfectly healthy but just naturally petite, or if there's an actual underlying issue preventing them from growing, is one of the biggest challenges in obstetrics. Getting this wrong can lead to totally unnecessary interventions, or even worse, missing a baby that's genuinely in distress. To figure this out, we are unpacking the official, peer-reviewed clinical guidelines straight from the Royal College of Obstetricians and Gynecologists, published right here in the BJOG. Specifically, we're looking at their Green Top Guideline number 31. This isn't just medical theory. These are the exact evidence-based protocols that doctors and midwives follow to monitor and protect pregnant patients every single day.
Here's our roadmap for this explainer. We're going to define what SGA and FGR actually mean, spot the risk factors, compare early versus late restriction, look at monitoring and medical action, and finally, timing the delivery safely. Let's get started.
Section 1. Defining SGA and FGR. The absolutely crucial foundation for this entire pathway is untangling the terminology. First up, we have small-for-gestational-age, or SGA. In plain English, this just means the baby's estimated weight or belly size is measuring below the 10th centile for its age. But here's the big takeaway. An SGA baby might just be genetically wired to be small. Just like us, babies come in all shapes and sizes. So an SGA label alone doesn't automatically mean panic. Now let's put that right next to fetal growth restriction, or FGR. This is the big one. FGR implies a pathological restriction. Basically, the baby is literally being held back from reaching its genetic potential, usually because the placenta, the baby's life support system, just isn't transferring enough nutrients or oxygen. And here is a wild fact. A baby could actually measure above the 10th centile, but still have FGR, if they were genetically destined to be much larger.
Section 2. Spotting the risk factors. Knowing the massive difference between a healthy small baby and a restricted one, the clinical pathway immediately kicks into high gear to figure out who's at risk. By 14 weeks, doctors are looking closely at a patient's history. Has she had a previous growth-restricted baby, or a history of preeclampsia? What about physical factors, like an extreme BMI, or being over 40? They also look for complex medical conditions, things like congenital heart disease or diabetes. Spotting these red flags early on literally dictates the game plan for the next 9 months.
And this is where the guidelines are just brilliantly proactive. If you are flagged as high risk early on, doctors don't just sit back and watch. Nope, they'll often prescribe a simple daily 150 milligram dose of aspirin, taken right at bedtime starting from 12 weeks. It's a tiny intervention, but it significantly improves blood flow and massively drops the chances of FGR even developing in the first place. Talk about a game changer, right?
Section 3. Early versus late restriction.
So if doctors suspect growth restriction, they split it into two totally different timelines. Early FGR happens before 32 weeks, and it's tied to major, severe dysfunction in the placenta, causing a dangerous lack of oxygen. It carries a much higher risk, but honestly, it's usually pretty obvious on a scan. Late FGR, on the other hand, hits at 32 weeks or later. The placental issue is milder, but because the baby's bigger and the signs are so subtle, late FGR is actually way harder to catch on a routine ultrasound. It's kind of a hidden danger.
To nail down the exact diagnosis, doctors use these incredibly strict rules called the Delphi consensus. It's like a clinical puzzle. They look at the baby's abdominal circumference, their estimated weight, and then they use these super precise Doppler ultrasounds. These Dopplers measure the actual blood flow resistance in the mother's and the baby's arteries. If that blood flow is highly resistant, or no way, even flowing backwards, that is a huge red flag. It clearly separates a failing placenta from a baby who's just happily small.
Section 4. Monitoring and medical action.
Once the risk level is set, the pathway locks into a super strict schedule. This timeline is basically the doctor's playbook. Everyone gets assessed by 14 weeks. High risk, you get specific Doppler checks around 20 weeks to see how the placenta implanted. Low risk, from 24 weeks on, you just need regular belly measurements with a tape measure. But if you're in that moderate risk zone, or a Doppler looked weird earlier, you're bumped up to regular ultrasound scans to watch that growth trajectory like a hawk.
The timing of these scans is incredibly calculated. For babies officially tagged as SGA, doctors need to take measurements every 2 weeks. You literally need that 2-week gap just to accurately see any difference in growth. Meanwhile, moms with a moderate risk get scans every 4 weeks, starting at 32 weeks. This is specifically engineered to catch that sneaky late-onset FGR we were talking about earlier, making sure it doesn't just slip right under the radar.
Section 5. Timing the delivery safely.
All of this rigorous monitoring builds up to the biggest decision of all. When is the safest time to deliver? The guidelines lay out clear, step-by-step logic. Doctors have to balance a really delicate scale here. What are the risks of leaving the baby in a failing placenta versus the risks of pulling them out early? Step 1, check the baby's well-being. Step 2, figure out for sure if it's healthy SGA or dangerous FGR. And Step 3, use that data to carefully plan the birth somewhere between 37 and 39 weeks. The guidance here is just spot on. As you can see, if a baby has late FGR, meaning we know for sure the placenta is struggling, birth should happen between 37 weeks and 37 weeks plus 6 days. But if the baby is just constitutionally SGA, meaning they're tiny but their blood flow is totally fine, they can safely cook until 39 weeks. This is a massive win for modern medicine. It stops thousands of healthy small babies from being induced early for no reason, while still rescuing the ones who truly need it.
Ultimately, this whole intense pathway, from that very first 14-week check to the daily aspirin, right down to the delivery room, it all boils down to one thing, perfectly captured in this quote from the guidelines: targeting intervention for those at increased risk. It's about completely removing the guesswork from obstetrics and making sure both mom and baby get the safest possible start. So the next time you hear about a baby measuring small, you'll know the incredible, life-saving detective work going on behind the scenes. But it really makes you wonder, as ultrasound tech and machine learning get even more advanced, just how much more precise will our timing become in the years ahead? Thank you so much for joining me for this explainer. Keep learning, and I'll see you next time.